क्या थी हलूस बोले सर्जरी मतलब
The content is sent to the third party. Yeah. Who you're sending third party? Hi, Vismay.
हेलो
What
मैम
you're doing? Yeah. Please sit down. Listen
स्क्रबिंग
to the
इट
class.
फॉर सर्जरी सर्जरी
Who? Who is doing? Yeah, please sit down.
No, it's okay. You ignore him. He wants to wash up for a myomectomy. It's only 36 weeks myomectomy. Start. We are live on YouTube.
Okay. So good evening, everyone. I think after a few days of break, we are back to doing these fertility master classes. Today's topic is quite an interesting one. The topic being microTESE, and I have been fortunate to see a few of the procedures in microTESE done by Dr. Jay at Bangalore. And this has been such a revelation for me also, as the procedure, and also as to how rewarding it can be when a patient with non-obstructive azoospermia comes to us. And today we are going to know about the principles and also practicalities of the microTESE. So over to you, sir. You can take over. Yeah.
He went off probably.
Yeah, some signal issues, I think,
Yes.
sir. I think he will be back. So we'll discuss about that video also, sir, for 1 or 2 minutes.
Ah.
Yeah,
please
Shilpa
go.
madam, tell.
Yeah.
Sorry, I
You
lost
tell
the
now.
internet.
I finished.
Yeah,
I
okay.
finished
So
the
I will
video.
share the screen. Sorry, I missed out. I'll share the screen, but before I share the screen, I just want to give a. I'm again going to try and finish this in 15 to 20 minutes, but I want to give a concise overview on microTESE for non-obstructive azoospermia. All right. So remember, as far as the law is concerned, it is mandatory that either an andrologist or a urologist who has both of these guys should have had more than 15 cases done for microTESE, or a general surgeon or a reproductive medicine specialist. All these guys are allowed to do microTESE or any andrology based procedures. So even much before the law came or kicked in, what we were doing at our place is that we have somebody who is very good in our team. His name is Dr. Alap Mehendle. He's our urologist and he does all the renal work here. And we used to learn and ask him to open up the testis, and we would both, myself and Dr. Alap, look at the high probable zones. And much before that, I was doing it all alone. But there are a lot of fine points which you will learn from Dr. Alap, and I'm going to request him to take a session on how to open and close the testis. It's beautiful the way he teaches it. And I think it will help people who don't have the facilities and who want to learn from somebody as good as him about that technique, because careful handling of this tissue is very, very important, because manhandling is going to, in the future, follow up, reduce the testosterone level of these guys, and is not going to be helpful for these guys long termly. So you need to ensure that somebody good who knows these procedures and has been having an experience does this procedure for you. Okay, that is the first thing. Second, please understand, in non-obstructive azoospermia, you will try to roughly divide it into 2 or 3 categories. Is the testis normal in volume? Is the testis normal in size? Okay, and is the testis normal in consistency? So I'm going to draw that flow chart for you as to how and which patients you are supposed to ideally go ahead with a direct microTESE, and what all investigations are you supposed to do for these patients before doing the microTESE. And I will show you the microTESE procedure, how it is done, what are the outcomes, and what all things are you going to expect out of this. All right. So very quickly, I will start sharing the screen. Shilpa madam, I am audible, right?
Yes, yes.
Fine. So we have a very good systematic flowchart based approach as to whom to take for microTESE. Okay, and it's really a very, very easy thing. Okay, so microTESE, basically it is only for non-obstructive azoospermia. Your checklist pre-surgery is going to be FSH, LH, testosterone, prolactin, TSH, estradiol. Role of estradiol is more in obese patients, okay, not very much in thin patients. Along with that, it is better to do a karyotyping and Y chromosome microdeletion. Okay, these are the important things which you have to do. There is no importance of doing a USG of the scrotum, but we do it. Okay, this is not recommended. No guidelines say that mandatory to do a USG scrotum prior to the surgery, but we always do it because we have it as a protocol since the past 6 years. Okay, so we are not going to change the protocol for anything, and this is what we do as a checklist. All right, so now normally testicular volume normal, reduced testicular volume. Okay, these are the two things. So basically just keep in mind when your palpation is there or ultrasound is there, you will come to know about the volume. You will have a rough idea about the testicular volume. Okay, when the testicular volume is normal, okay, what we normally do is that once we take the patient in the operation theater, we do a TISA, just a TISA first. Okay, if in TISA we get sperms, then obviously, if sperms are found, so if sperms are positive, you go ahead and do ICSI. If there is sperm negative, so if there is no sperm which you have found in this situation, then you will be doing a microTESE for this patient. Yeah. In low volume patients, almost always you will have to do a microTESE only directly. All right. Remember one more thing. FSH alone, okay, is no indicator for finding or not finding sperms. So if you try to study the architecture of the testis, if I look at the testis like this, okay, the testis is located here. All right. If you try to study the architecture, it is divided into several compartments, okay, micro compartments. And you must understand that you can have only a very small focus which is producing healthy sperms. Bas, this much is the small focus which is producing healthy sperms. Rest everything is abnormal. In this situation, the FSH value is going to be elevated despite this particular focus of sperm being normal. Okay, which is why FSH alone is not going to be of any great help. Okay. Second thing, please keep in mind your pre-surgical injections of HMG and HCG are only going to benefit in cases where FSH and LH values are low, which is going to be a case of hypogonadotrophic hypogonadism. In all other cases, it is experimental. Even in patients who are very obese, when you try to give letrozole 2.5 mg, it is not going to work in all the patients, though we give it in order to reduce the estradiol levels. So once the estradiol level goes up, the testosterone to estradiol ratio, it is called as T to E ratio, it stabilizes and it may enhance the chance of sperm retrieval. Simultaneously, doing a varicocele surgery prior to non-obstructive azoospermia microTESE, in my opinion, it has got no role. It does not benefit anybody. But I know of some people who say that if it is a very severe palpable varicocele, it is better to do it. Okay, but even they are not convinced about it, but they just say it is better to do it. But in my opinion, that thing, varicocele surgery prior to microTESE, has got no role. Okay, just keep that thing in mind. And there is one surrogate marker which may help you identify something. If the testosterone value of the patient is more than 350, okay, irrespective of FSH and LH, it usually indicates that the concentration of testosterone which is required for sperm production is going to be good inside the testis, and it will help the patient having some good chances of getting the sperms. All right. How are you supposed to do the microTESE? So I will just show you the microscope which we are using for doing the microTESE. Let me just go back to Zoom, and probably I can turn my camera and show you the microscope for the benefit of everyone. So if the microscope has been got ready, see, here is the microscope which is ready in the OT, and let me just switch the camera. Can all of you see it?
Yes, yes.
See, this is the microscope which we use. Okay, this is called Labomed Prima. It is a commonly available microscope. We used it for 2 cases today morning as well. The one which I had posted, it is mounted on a wheel. You can put it inside, outside, wherever you want to put it. And see, this is the point. Okay, this is the same microscope which is used by our colleagues even in ENT and even in neurosurgery. Can you see the eyepiece here? See, this is the eyepiece which is present here. Okay, and with the eyepiece, you have these knobs. Can you see the log-based magnification which it can offer? Can you see this?
Yes.
0.6, 0.4, 1.0, 2.5, 1.6. All this is the amount of magnification which this particular thing offers. So it can offer up to 20-25 times magnification of the testicular tissue. And this thing gets mounted. This entire thing gets mounted right above the testis. So when it gets mounted right above the testis, this is where you look at. This is your eyepiece. You can adjust the focal length from the eyepiece and you will look straight into the testis after you open. Okay, after the testis is opened, your eye will look straight inside this. Okay, and you will be able to then magnify the testis in order to look at the seminiferous tubules. And that is very, very important, because once you want to look into the seminiferous tubules, you will see something like this. See, I'll show you. So I have again shared screen, and I hope you guys can see this video, right? Shilpa madam, see?
Yes, yes, yes.
Yeah, so see, this is what the ultra microscopic picture of the testis looks like. So if you look here right in the center, always try to focus in the center. You will see these small seminiferous tubules, which have this vascularity. Can you see these tiny capillaries right in the center? We'll put some flush over it. I think in this video, we've put some water. Continue. See that? That just takes away that blood. So this flushing is very important. It helps you identify, pick up the high probable zone, which is right now right in the center. You can see that small capillary in the center of the screen, which is going in through the tubule. You can see that tubule is slightly dilated. Okay, it is slightly more pinkish in color and slightly more dilated. Okay, as compared to the rest of the tubules. Of course, the vibration which you are seeing is because of the microscope. And you can see the rest of the tubules beside it. Can you see these small seminiferous tubules? The very tiny ones, right? These tiny seminiferous tubules are not going to yield any sperms. It is just that high probable zone area. So basically, in ultra high magnification, you got to pick up this highly probable active areas for getting the sperms. And then once you pick up these particular areas, these tubules have to be picked up from there and have to be sent for laboratory testing. I mean, they need to go inside the laboratory and person has to evaluate if you are able to get any sperms from them or not. So that is the most important thing which you have to remember as a part of this procedure. When you are doing this procedure for anyone, just keep that in mind, that this is what you are supposed to evaluate in that particular patient. Usually, what will happen is that whenever something like this is being evaluated by you, when you go inside the laboratory, you need to be good at preparing this tubule, identifying this tubule, how this tubule is, and then looking at the tubule from inside. Okay, so I'll just share the video for that. See how it works inside. So see this. This is how you will find the sperms. Can you see the sperms here in the center? See, this is a non-motile sperm. All right, but this is a tubule who has a sperm inside it. All right, now can you use this sperm and can you store this sperm? That is a different story. I will come to that in the next 1 to 2 minutes. Please try and understand that whenever you find sperms like this, but the sperm is not motile. Can you see that red spot on the screen? That red spot on the screen is the laser. Okay, that laser is going to help you stimulate these sperms, and the sperms which are going to be alive, their axonemal membrane will break and the tail will get bent. Okay, so once the tail gets bent, that is the sperm which you can use for doing ICSI, even if it is non-motile. Okay, in non-motile tubules, we usually do not try to preserve the tubules. If it is a motile sperm, then we try to preserve the tubules, because we have seen that individual tubular freezing as well as individual freezing of sperms, both these things give you a very good retrieval rate. Commonly, patients will ask that why don't we do microTESE simultaneously at the time of doing egg pickup? Of course, you can do that. There is no harm in doing that. But remember one thing, if the patient does not find sperms, then in that situation, you will have to freeze all the oocytes till the couple comes back to you, with a decision if they want to go ahead with a third party reproduction or not. So just keep that in mind. So with this much basic understanding, of course, the testicular tissue is closed. after doing this in micro layers. We use 3-0 monocryl or sometimes 4-0 monocryl in order to close the tunica albuginea layer by layer above that. Okay. Structures above that, and the dartos muscle is closed, and then the skin is closed subcuticularly, and the patient is usually sent back home within 8 hours of the procedure. So patient can literally travel after 8 hours. There is hardly any tissue edema which you see after on this patient. Patient can experience pain for the next 3 to 4 days, but it is comfortable enough for them to go and work. Okay, which is what we have seen in these types of situations. So with this, I come to a conclusion of my 15 to 20 minutes of microTESE and non-obstructive azoospermia. What I wanted to show you was the microscope, identification of the high probable zones, and then how do we look at it under the microscope to see the sperms. All right. Please remember one thing. No matter how beautiful you are at doing microTESE, even if you are the best person on earth, okay, the normal sperm retrieval rate in this procedure is not going to be 100%. In non-obstructive azoospermia, even if you have a testis with good volume and you don't find sperms, that is common. That happens in viral orchitis. Okay. And when you have a low volume testis, you may still find excellent sperms. That also happens to a lot of people. So don't really make high promises in non-obstructive azoospermia patients. It is important to understand that your total sperm retrieval rate on an average, our annual sperm retrieval rate stays at approximately 50%, not more than that. 6-7 years ago, when we were starting to learn all these things, I am self-trained into all these things. Nobody used to really help at that point in time. That time, my sperm retrieval rate was only 15 to 20%. But I had invested in the microscope because I wanted to be the best as far as non-obstructive azoospermia is concerned. And this long-term efforts of doing this have paid off. Simultaneously, I also want to tell you, when we do an ultrasound of the testis, our Visma is very good at doing these ultrasounds, and he picks up those small patches of fibrosis. Okay, so when you have this large spokey fibrosis going inside the testis, usually it is an indicator of maturation arrest. And when you have a maturation arrest, Sertoli-only syndrome, in that situation, your sperm retrieval rate is going to be approximately 10%, 15%. Okay, that is important. Also, very important for all people to understand in this situation is that when you do a particular microTESE, it is important to explore both the testes. Do not just give up after doing one testis. MicroTESE is a long procedure. It can take approximately 2.5 hours for people to do it. And even if you call a urologist, andrologist, general surgeon, oncosurgeon, whomsoever you want to call, you call. As long as they don't know how to see the high probable zone, they will not be able to give you a sperm retrieval rate. Irrespective of the degree, that sperm retrieval rate will not come, because identification of high probable zone is a very, very important thing. And of course, we've learned it over a period of time. It is not, there is a learning curve to this procedure, irrespective of who you are. Okay. And this learning curve, once you cross this learning curve, then you will become good at it. You will not become good at it without that. Okay. So with this, I conclude. I can answer 2-3 questions if anybody has, and then we can take the rest of the questions on WhatsApp.
So what is the cost of this microscope?
So see, this one which I have is 3-axis and all. So this one costed us approximately 26 lakh rupees that time. There is a microscope available from Carl Zeiss as well. This is an Indian microscope. So this is a German microscope, sorry, Labomed. There is a Carl Zeiss microscope with an expensive lens. It goes to approximately 55 lakhs.
Okay, and what's your live birth rate post azoospermia in
Around 15%.
Okay, and does it require microTESE to be done at every time that you want to do?
No. We preserve the sperms on sperm VD if it is good enough, madam.
Okay, so what is sperm VD? Vitrification
It
device.
is a vitrification device which allows you to isolate and freeze motile sperms. So every drop of sperm VD, you can store approximately 10 sperms.
Okay. And how do you prepare these sperms prior to putting it in VD?
We incubate them for 2 hours, madam. Then we put them in the VD.
Why?
That is because motility goes up. When you incubate a particular tubule, no, some motility goes up in the IVF media. So it is easy to pick those sperms.
Okay, and how to clear off the debris from a testicular sample?
You will have to either wash it, or you will have to become very good at mashing the tubules. Like how you mash the tubules, that is very, very important.
Washing with what? Media?
You can wash with HIPPIS, madam.
HIPPIS, yeah. And yeah. So, what about the sperm retrieval rate in Klinefelter syndrome?
2%, maybe 5%, not more than that.
Okay, and how do you counsel these patients? See, like how you said during the OPU, I don't suppose that you do it on the day of OPU. You always do it prior to that, and then
Yeah.
take it as a next step to do the IVF. So,
See, 80% of our patients will do a sperm retrieval before the OPU. Okay. So we already know if he has the sperms or not. There will be some people, madam, who are comfortable doing it simultaneously, and they are like, "Nahi sir, nahi mila to chalega." You just freeze the oocytes.
Yeah.
That's a different story, madam. But 80% we counsel them to do it before and only because we don't like that surprises on table. Acha, now what? Now what? Like that we don't like.
So see, this orchitis, can it be diagnosed clinically? Because last time we missed it in our setup, and there were no sperms which were retrieved.
Normal test is no sperms.
Yeah.
Correct, no?
Yeah.
And in an abnormal test is we got sperms.
Yes.
Correct?
Yes.
So that is common, madam. That is how microTESE is. That is how azoospermia is.
Okay. So among all the tests that you said, which is that one test you would like to do before a microTESE rather than doing all the battery of tests?
Testosterone.
Only testosterone. So if it is
If
about
it is more than 350, I am happy. And of course, clinical examination.
Okay. Yeah. Yeah, sure.
See, I tell you, normally in cryptorchidism, we don't find sperms very easily. Okay.
Yes,
But
yes.
you remember you had sent a doctor couple to me from Hyderabad. Then they
Yes.
came to Bangalore and then they came to Bombay. It was such a
Yes.
tough case, but he got sperms. And the family was so happy because in that the sperm retrieval rate is just 10%. We had written it on his file that your sperm retrieval rate is 10%, my dear. Aana hai to aao. And he came, he got sperms. Right?
Yeah.
So, see, for that guy who gets sperms, it is 100%, no?
Correct.
But the guy who doesn't get, we have to counsel them. Otherwise, people are sitting, there is no retrieval, he just speaks,
Yeah. So what about cases of obesity? Because we are seeing a lot more of these obesity patients with...
Very common to get non-obstructive azoospermia even after having bariatric surgery done.
Yes.
So obesity method will be there only, madam. The thing is, what I realized, I've spoken to 4 or 5 bariatric surgeons. See, when the estrogen is very high because of peripheral obesity, testosterone gets converted to estrogen.
Yeah.
Okay. So in that situation, madam, what happens is this sustained high estrogen. Okay. This sustained high estrogen is causing irreversible testicular damage to the seminiferous tubule because it causes very low FSH. Okay. And that is a big problem in obese guys. Very poor sperm retrieval rates. Okay.
Yeah. So you never do TEFNA, you never do PISA for any patients. You always do a microTESE in your setup?
No. Obstructive azoospermia, as I mentioned, this is only non-obstructive azoospermia. Obstructive azoospermia, TEFNA is the treatment of choice, madam. Just put a needle, take it out, you'll 100% get sperms, no? Not 100%, 98%. Why I'm saying is because the only place where obstructive azoospermia starts feeling like non-obstructive azoospermia is in viral orchitis. Okay. Where you will feel everything and you might just think there could be some block somewhere. That is why sperms are not coming. All reports are fine and still there is no sperm retrieval rate. Okay. And that happens to people who have been doing TEFNA for obstructive azoospermia. Commonly it happens.
How do we recognize this viral orchitis? I mean,
you have to look at the tubules. There will be these yellow microcalcific deposits in between the tubules, madam. Little small ones. When you do more, you will see.
But in TEFNA, it is not possible to see that orchitis features, right? Yeah. Okay. Yeah, I think we are good now. So I think we can wind up this session, and the rest of the questions we can take it on WhatsApp. Thank you so much for your time. I hope that this has been helpful for all of you who is listening to this for the first time. But I think it is quite a valuable skill and valuable, I think, technique which will help patients who have non-obstructive azoospermia to give them a chance to conceive with their own gametes. Thank you so much.